Here's an important question for doctors. Can you identify the primary acid-base disorder from this ABG? Please do not skip ahead in this clinical case. Think like you're standing beside a critically ill patient in the ICU. Here are the arterial blood gas values: pH 7.18, PaCO 268, bicarbonate 24. What is the diagnosis? Choose from metabolic acidosis, metabolic alkalosis, acute respiratory acidosis, or respiratory alkalosis. Choose from metabolic acidosis, metabolic alkalosis, acute respiratory acidosis, or respiratory alkalosis. Pause the video and make your diagnosis before moving ahead. Wait just a second and pause the video before moving ahead. Let's solve this systematically. Step 1, assess pH. Step 1, assess the pH. The pH is 7.18. A pH of 7.18 is significantly below the normal physiological range. Normal pH ranges from 7.35 to 7.45. This specific range represents the physiological normal. Since 7.18 is below 7.35, this patient is acidemic. This means the patient is in a state of acidemia. Now let's identify the primary process. What exactly is driving this acidemia, lungs or kidneys? PaCO2 is elevated at 68 millimeters of mercury. This represents significant CO2 retention. Normal PaCO2 is between 35 and 45. Our patient's value is well above normal. High carbon dioxide levels drive the pH downward. This is a direct relationship. This points toward a respiratory cause. We are looking at specifically respiratory acidosis. Next, evaluate bicarbonate. Let's see if the kidneys are helping. The bicarbonate level is 24. This is a key piece of information, and that falls within the normal range. Normal is between 22 and 26. This means there is no renal compensation yet. The kidneys haven't had time to respond. Therefore, this is an acute process. It's happening right here, right now. The correct answer is option C. Acute respiratory acidosis is the correct diagnosis. The final diagnosis is acute respiratory acidosis. The data confirms it perfectly. Low pH plus elevated carbon dioxide with normal bicarbonate confirms the diagnosis. Where do we commonly encounter this pattern? COPD exacerbation and opioid overdose are common causes. COPD exacerbation, opioid overdose, a severe asthma and hypoventilation. Failure to recognize this can lead to emergency intubation, can delay life-saving interventions. Here is a simple ABG interpretation pearl. This is a key clinical rule to remember. It's your first anchor. Then determine whether the cause is respiratory or metabolic. Now you must identify the driver. Assess whether the lungs or kidneys are driving the change. And finally, assess compensation. That completes the diagnostic picture. If you answered correctly, comment below. Subscribe to Medical Global Academy for more clinical insights. And turn on the notification bell for more clinical insights.